Good morning. My name is Dr. Greg Vina. I'm a board certified specialist in physical medicine, rehabilitation medicine, certified in life care planning, and also I have a personal injury practice in California as an attorney. This morning, I will be talking about your acute rehabilitation stay and a term you might hear, a term that I don't like. We hear of this term called length of stay. When you hear the term length of stay by the people who are providing your care, I want to make sure that you understand there's two ways to look at length of stay. Length of stay based on the payer source viewpoint, and the length of stay based on goals, which is your treaters, your doctors should be thinking about your length of stay based on what you attain, what they want you to attain prior to discharge. In the public sector, patients, for example, if they get admitted with a stroke, who are Medicare patients, they'll be admitted to a rehabilitation hospital where they will receive services such as physical therapy, occupational therapy, and speech therapy. And the facility will be plug in the computer their diagnosis, what other type of medical problems they have in the computer, and it will spit out a number of how many days you can have with that patient to get your full payment. Anything after that day, those days, that's your total payment. So if you keep a patient 4 months, you'll get one payment. If you keep the patient that specified time, you'll get the same payment. What does that do? It takes away the whole purpose of medicine is and the whole purpose of rehabilitation is get as much benefit, independence as you can during your acute rehabilitation stay, and then be discharged to outpatient where you could further refine your skills and your independence. This arbitrary number is designed by government payer sources and insurance companies who have every motivation to decrease the length of stay so they could decrease payment, and we've been slowly seeing a cram down in terms of how long people have been staying in the acute rehabilitation hospitals where they are receiving their care. I don't like that. The way we as specialists in physical medicine rehabilitation view length of stay, it's based on goals. It's based on what the providers feel like that patient can attain reasonably prior to discharge. For example, if you're a spinal cord patient, a T6 paraplegic young man with no real serious associated injuries or complications, you would expect this T6 paraplegic to be absolutely independent in all aspects of his care prior to discharge. He should be able to bathe himself, he should be able to get dressed, he should be able to make all of his transfers, he should be able to fully operate a manual wheelchair, do curbs, get dressed, manage his bowel program, manage his bladder program, plus understand all aspects of his care, the complications associated with his injury. He needs to be educated on numerous things in terms of proper bladder management, proper bowel management, proper skin management, and review all the complications that occur, see videos, and be educated on the complications so that patient is absolutely careful when he goes home to prevent complications at discharge. Historically, length of stay, for example, for a traumatic brain injury 25 years ago, they were in the hospital 3 to 4 months, over 90 days. Now the length of stay for traumatic brain injury for an acute rehabilitation stay has been crammed down to 30 days. You think that rehabilitation has changed so much in 25 years? It really hasn't. It takes individualized therapy. It's painstaking therapy, one-on-one with a therapist, to develop all the skills necessary to maximize independence. This cram down that has been going on because of government payment pressure, as well as private payment centers, is going to hurt your care unless you participate actively in your care. So, in sum, this length of stay term that you hear, it needs to be based on goals. And how do we determine what the goals are for your acute rehabilitation stay? It is determined in a team meeting. In a acute rehabilitation hospital, you'll have a team meeting once a week, and I encourage you to be involved in that. You could go to the team meeting. Your family members could go to team meetings. Your attorney can go to a team meeting. Anyone can go to a team meeting. That will involve the physician, usually a physiatrist. It will include physical therapy caregivers, occupational caregivers, speech therapy if you've had a brain injury. It will include recreational therapy. It will include psychologic services, either a master's level or a neuropsychologist or a counseling psychologist, whatever you may need. The case manager, a nurse, the chief nurse, or the nursing supervisor. And we all sit down. We sit down and talk about each individual patient, about what is going on with that patient currently, what we expect that patient to be able to do in 1 week, 2 weeks, and at discharge. Then we talk about discharge planning regarding what kind of home modifications, what kind of equipment, what kind of outpatient therapy does he need, what kind of medical follow-up will this patient need, what kind of vocational training will this patient need, what kind of educational support will this patient need, what kind of assistance can this patient have going forward. These are all very, very difficult issues, and they can't be done with an arbitrary, crammed down length of stay. It needs to be, this length of stay needs to be determined by goals, and the length of stay will change. If you have had a medical problem, if you develop a pneumonia during your stay, you're going to have to stay longer. If you've unfortunately developed a bladder infection, you'll have to stay longer. These are setbacks. And medical setbacks do happen, and this arbitrary length of stay number is absolutely not going to help you in terms of getting fully independent. Again, I'm Dr. Greg Vigna. I'm here to help. Any questions or concerns, I'm available for you.